Okay, Chapter 11, Caring for Multicultural Healthcare Environments. Disclosure statement, I don't own this material. Under fair use, I'm providing lecture content for only my nursing students using this material. All content within is only for educational purposes for nursing students and does not provide medical advice. So, cultures and ethnicity. This brings back good memories of HCR 230, right? So the United States is a multicultural society. You're going to care for clients who are not from your culture or your race or your group or your religion. So cultural characteristics, cultural beliefs provide identity and a sense of belonging to people. Culture is both universal and dynamic. Cultural values, beliefs, and traditions are passed down from generation to generation. Cultural assumptions and habits are unconscious. Culture is diverse. So there's ethnicity, which is members share common social and cultural heritage. There's race, based on biological similarities. And then religions, which are ordered systems of beliefs. So concepts related to culture, when we think about cultural considerations, think about the socialization of that culture, the acculturation into the United States, assimilation into the United States, or whatever area you're providing healthcare in, the dominant culture of that group, of that area, the subcultures in that area, and the minority groups. So, some vulnerable populations as subcultures. Vulnerable populations, we're usually talking about the homeless, people experiencing economic instability, mental illness, physical disabilities, the young, the older adults, and some ethnic and racial minority groups as well. So when we talk about vulnerable populations, that's who we're considering in healthcare. So clicker check, the most important concept about vulnerable subcultures guiding nursing care is that persons belonging to these groups receive different healthcare, have difficulty complying with their therapy, never have insurance, or often have limited access to healthcare. So if you think back to HCR 230, those vulnerable subcultures that we looked at, 3 of these are considered stereotypes, right? So you never want to do that. So subcultures being vulnerable means that you are generally having a lack of access to healthcare. That's common to vulnerable populations. If you cannot afford healthcare, you're not going to seek it out. If you're in a rural versus an urban area, you're not going to seek it out. Specifically, Native Americans on reservations generally have vulnerable population attached and IHS hospitals out on the reservation because they're so far away from larger urban areas. Safe and effective nursing care. Here's a question for you. A student nurse is assigned an undocumented immigrant injured while crossing the border into the U.S. The student tells you, I don't know what to put for race. You probably can't tell me. What's your best response? So how do you fill out race? Do you leave it blank? Your response demonstrates that you don't know the difference between race and ethnicity. You should be able to determine the race by his skin color. Let's discuss approaches to obtain data on race from patients. Which one do you think would be the best? Definitely don't want to leave it blank. You've got to get that information, but how? So the most appropriate response would be, let's discuss approaches to obtaining data on race from patients. Okay. Cultural universals are values, beliefs, and practices of people from that people from all cultures share. Universals. Cultural specifics are values, beliefs, and practices that are special or unique to a culture. Something recurrent based on fact, archetypes, and stereotypes are widely held but oversimplified beliefs that have no basis in fact. Cultural specifics that affect health. So we talked about this in HCR 230. Communication with them and others in the healthcare environment. Space may be very different. Being 6 foot is a standard that may be more or less based on a specific culture. Time orientation, when you tell them that there's an appointment at 9 o'clock or in the morning, very different specifics there. They might think 9 a.m. as morning, not too early, and show up at noon. The social organization around that and the environmental control. Biologic variations, religion and philosophy education, technology, politics, law, and economy may all have an effect on health and healthcare seeking behaviors. The nurse notes that the client's grandmother is looked to for input whenever questions arise about the care of the client. Which cultural specific will guide the nurse's plan of care? So what is that called when a client's grandmother is looked for input? That's a matriarchal society. It's called matriarchal, mother, maternal. The oldest female in the room makes choices. So that's a social organization. That's an influence on that culture that the grandmother or the oldest female is the decision maker in the family. So that social organization of the family will influence treatment and what's acceptable or unacceptable to do to that patient. Indigenous healthcare systems, like I'm saying, the Native American healthcare system is much, much different. Professional healthcare system. The health and illness beliefs, there may be scientific or biomedical. There may be magico-religious beliefs of a certain group. And overall, we're always hoping to be holistic as possible. Holistic with an H, meaning mind, body, spirit, everything related to that patient's care. Nursing is a subculture. When you think about it, nursing is a complete subculture of healthcare. Nursing values, some nursing values that are common among nursing is that there's silent suffering as a response to pain, caring, nursing autonomy, the use of the nursing process, knowledge, critical thinking. So just in that, nursing is just one part of healthcare. Nursing is a subculture, medicine is a subculture, RT, PT, respiratory is a subculture. Traditional and alternative healing, we do have to be aware that there are complementary medicines that are used in the United States and elsewhere. So knowing about folk medicine, complementary medicine, and alternative medicines, that not only one type can be used in the healthcare setting. So traditional Chinese medications, things like that, the use of roots, plants, long-standing. In Leninger's cultural care theory, She has an entire theory around culturally competent care. And generally, culturally competent care means knowing what the culture is like and what their beliefs are, but also asking the patient because you don't know what level of involvement that they have in that. So it's always best just to ask the patient. The barriers to culturally competent care, as we talked about in HCR 230, biases, ethnocentrism, cultural stereotypes, prejudice, and discrimination can really impact our ability to provide culturally competent care. Racism, sexism, language barriers, street talk, slang, jargon, the lack of knowledge, their emotional response might be different than ours, and the self-knowledge might be different as well. So a charge nurse of a unit tries, as a rule, to admit Hispanic clients to a room at the end of the hall so that the noise from the family will not disturb others. This nurse is exhibiting totally discrimination. She is discriminating against Hispanic patients, that they should not be at the center of the unit. So that's behavior that results from a prejudice. Prejudice from Hispanic families bring their entire family and they're very loud. That's coming from a stereotype. Discrimination is the actual behavior. Prejudice would be a belief. Discrimination is the action against. So when you assess, just be careful when you're doing your health history and your physical assessment to be open and asking questions about, like, may I touch you? Can I remove this? Those kind of things, because when you're assessing, you really want to be culturally competent. If there needs to be a male in the room, if there cannot be a male in the room, you know these things. While you're analyzing your data and making a plan and providing outcomes, remember that your nursing diagnoses and outcomes need to reflect the culture that you're providing care for. So when you say increase protein, increase red meat may not be culturally, socially acceptable in certain cultures. So you have to be aware of that. They love that test question on NCLEX. They love to ask the vegan or someone who doesn't eat meat, how are you going to provide that protein? So just be aware that there is a lot of questions that pop up on tests in school, but also the NCLEX about culturally competent care. Possible effects of a patient's cultural health practices. When the practice is efficient and okay, is that okay? If it's neutral, then it's fine. If the effects of the practice are unknown, but when the practice is dysfunctional, think about, is that a good thing or a bad thing? Okay, patients have rights, but we have to be honest and open about their use of herbs, other practices, things like that. So being non-judgmental is most important. Sometimes the practice is better than medicine, sometimes it's neutral, and sometimes it's just unknown yet. So consider this like the use of marijuana. There's a lot of research for and against, and a lot of it we just don't know yet. A lot of it we also know, but it's being held underneath because medication comes first in a lot of cultures. Nursing strategies for responding to a cultural health practice. Always negotiation. Do not say, you can't do that. Say, let's talk about, restructure, repattern that thought process. Let's talk to the pharmacist. Let's see. Okay. So a lot of it is tell me what you're doing so that I can look it up. Then we can make a decision. Do not say no right away. Do not say yes right away. Be very careful. You also want to consider bringing in an interpreter. either internet, computer translation software, a translator. You can even use Google Translate if that's your hospital's policy, but always follow your hospital or healthcare organization's policy because that's what's going to get you in trouble or keep you out of trouble. So if it says you need to have an interpreter, that is not the son or daughter, that is a medically certified interpreter. If you want a good side job, be a medical interpreter. You have to be certified for it, but it is quite beneficial. Developing strategies. So let's talk about strategies. So reflect and know yourself, keep learning, accommodate and negotiate, collaborate, respect. Okay. Overall, that's how you kind of want to do this. It's okay to take a trip to Bali. Take a trip in their shoes. What is this like? What is this about? Being an open minded, inquisitive person. So, becoming a culturally competent person, there's two mnemonics that we like to use a lot: live and learn. Live is like, inquire, visit, experience. And learn is listen, evaluate, acknowledge, recommend, and negotiate. Okay. So just some saccadic reasoning. A 67-year-old patient is brought to the emergency room at 0230 for injuries received in a motor vehicle accident. Her husband died in the accident. She's alert, oriented, and only speaks Russian. No one at the hospital speaks Russian. Several diagnostic tests are needed immediately to determine the extent of her injuries. Internal bleeding and other potential life-threatening injuries are suspected. Her blood pressure is 98/60 and her pulse is 120. What would you do? So what do you do about informed consent? Who can give informed consent? Her husband died in the accident. Who's next of kin? How do we even know where they are? Okay. Is there an ability to waive informed consent? So typically the providers can waive informed consent under emergency services needing to be provided. But obviously we would want to try to get a phone number off her phone or his phone. Look in their phone for an ICE number, which is in case of an emergency. Make sure you have an ICE number in your phone. It's always best to have an informed consent, but when needed in an emergency, it is okay to do the actions that you need ethically. You will be covered on that. What options are available to assist the patient? Depending on what her, she's alert and oriented, so she can still speak. So you should use an interpretation line. What should your initial actions be? Don't shy away from her. Provide her care. Provide her as much information as you can in English, knowing that she may not understand everything. Okay. Definitely try to get a next of kin for sure. Making motions like phone call, those kind of things. You can do a lot in the time that you have with her. She does have an internal bleeding and potential life-threatening injuries. We're obviously going to take care of her. Unless we have a DNR in our hand, we do as much as possible to save somebody. She's only 67. Okay. That's kind of the goal with that care. Thanks.